Do you feel like you're learning a lot from the videos on our channel? Most of those videos are part of our online EMT course through Idaho Medical Academy. With the flexibility of an online course, you can take it anywhere, then join us in one of our skills locations to learn the hands-on skills. We also have an online AEMT course for EMTs who want to expand their skills and knowledge. We are currently offering a discount to our subscribers who want to take an EMT or AEMT course. Reach out to us at info@idahoacademy.com for more details. Or for more information on what courses we offer and the course details, please visit idahomedicalacademy.com.
Okay, so today is going to be chapter 14. It's a focus lecture on shock. It is a general overview, and it does go into the standard, like conditions that we think about, like tension pneumothorax, cardiac tamponade, PEs, all that kind of stuff. But more importantly, I think it goes into just the general pathophysiology and recognition of shock. Whether you see these conditions or not, you're going to see shock patients, and it took me a while to kind of realize that they were actually shock patients. And that sounds silly, but if you've been in the field for long enough, you kind of know what I mean, is in like, you realize it's a septic patient in front of you, but it doesn't occur to you that they're hypotensive, tachycardic, febrile, all these things, and you look at it and you go, oh, this is a shock patient. This is what we've been talking about this whole time. I notice the further we get into care regarding like IVs and things, which don't as much come up in here, but fluid resuscitation does come up a little bit. The further we get into like our treatments and things like that with fluids and medications, the more we forget about just really how basic shock is. It's really not that complicated. In my mind, I'm sure I say that and people probably hate that, but I think shock's pretty straightforward when you consider just the few components of it that we'll get into here in a little bit, and those being the three big components of like the heart, the pump, the blood, and then the blood vessels. So shock is a state of collapse. That's what you've probably heard forever. Shock is a state of hypoperfusion is the word we usually hear, and that's the one the National Registry really likes. But I also appreciate the cardiovascular collapse because like I was just talking about, cardiovascular implies the heart, the blood vessels, the blood, the lungs. It's not included as much in here, but please don't forget the lungs. They are very important in the general picture of your body functioning, but cardiovascular system as well. So remember, whenever we are in a state of shock, the body is always going to try to maintain homeostasis. And generally speaking, it does a pretty good job, depending on what the reason is or what the condition is that puts you in a state of shock. The body does a pretty darn good job. It's when it becomes overwhelmed that we reach that state of hypoperfusion where we start seeing symptomology. Eventually, that's going to cascade, like it's going to cascade down into ultimately death if it's not treated. Ideally, we'll get there, or we'll start an intervention. Maybe not even just us. The patient will get intervention of some kind, and then that process will cease. Hopefully, ideally, we'll get there before we even start to see signs and symptoms of shock, but not always the case. And if you've worked in 911 before, that's definitely not the case. So for some of the pathophysiology or general physiology, we're going to talk about cardiac output really quick. There's two words on here that I'm going to use a lot throughout this lecture. They come up for me in my world a ton, in the ALS world. I hear it not as much in the BLS and ILS world, but I reference them a ton, preload and afterload. Preload is the volume that's going into the right side of the heart. That gives you an idea for conditions that have low fluid volume, right? So they're low on preload. Your afterload is the systemic blood pressure that your left ventricle is pumping against. So that gives you an idea for other conditions where you might have like a blood clot somewhere, like a PE. Preload and afterload are super important when you not just talk about shock, but you just talk about overall patient assessment. You'll see patients who have low preload because they have low fluid volume, whether it's a shock situation or not. Whether it's a critical shock situation or not. Sometimes people have transient episodes where they have low preload or they have increased afterload. That's a much longer conversation for other lectures, but preload and afterload are not just affected by shock states. Myocardial contractility, if you break that word down, myocardial, myo means muscle, cardio means heart. So contractility, when we're talking about cardiac contractility, that plays a huge role. And there's other things that play a role in cardiac contractility that we don't talk about too terribly as much. But the big one here that I want to reiterate is contractility. You've also got the conduction and then the heart rate components of it as well. We talk about heart rate a lot, conduction not as much, but contractility should be recognized a little bit more in my mind. Here's some important phrases to keep in your mind. Cardiac output equals heart rate times stroke volume. Whether you're using real numbers or not, that is a very valuable idea to keep in your head. I do. Usually when I'm looking at any patient, I've kind of broken it down to this. I say like, okay, cardiac output, what does the patient look like, right? Heart rate, what's their heart rate doing? Easy to figure out. Stroke volume, that has a lot to do with, is the patient dehydrated? Are they oversaturated with fluid? You can actually figure out a lot just by paying attention to those few things. Blood pressure, if you want to calculate blood pressure, there's your equation. But to be honest with you, when we talk about blood pressure, we're really talking about the 120/80, the golden 120/80 or whatever number. We don't have to worry about the equation as much. MAP is a really good thing to know, and I will be honest with you, I wish I knew it. I don't know this off the top of my head. I can't think of a lot of people that do. That being said, if you have a monitor that tells you the patient's MAP, super valuable. MAP is one of those things that as you start talking to higher level providers, you'll realize plays a huge role in overall decision making, especially at that higher level regarding medications for like pressors, if that word sounds familiar to you, and things like that. MAP is going to give you an idea of just how well your patient's actually doing with their blood pressure and if it's actually perfusing their internal organs. So MAP's going to come up some, but just remember we have to have good MAP. Blood pressure is a part of that, but MAP is what it actually takes, the pressure it actually takes to perfuse our kidneys. When our kidneys lose that perfusion, it's not that all bets are off, but the bets change. They significantly change. The kidneys are the primary game player in your blood pressure management, actual management of it. You also have the autonomic nervous system, the parasympathetic and sympathetic. I always mention the fight or flight and then feed and breed or rest and digest, whatever you're familiar with. That is significantly influenced by different patients, actually. If you think about it, your spinal cord injuries, not just our typical shock patients like I was talking about, but even some of our toxic overdose patients. Regarding your parasympathetic nervous system, if that sounds familiar, as you're in the advanced program, you'll start to hear more about that kind of stuff for overdoses regarding the parasympathetic nerve. But remember, the autonomic nervous system is controlled by the medulla oblongata. That's in the brainstem. That is the big area for control of the higher functioning things like, or I shouldn't say higher functioning, the basic functioning things like blood pressure management, respiratory rate management, blood pH, things like that. When you need it, your body will activate fight or flight, and you'll be running from the saber-toothed tiger. When you don't need it, after you ate a big meal, or say you're resting, you're about to go to sleep, then you'll do that. Your heart rate will go down. It just depends on what your body needs. It will go into the sympathetic system, more towards the parasympathetic system. Well, again, when you're getting into those activities where your body's more vulnerable, you're not paying attention to your surroundings. That's why you're sleepy. And that's why if you compare these two, you're going to see the physical presentations. For this one, it shows that there's food in the belly right here. And that's where it's saying like, okay, rest and digest, or feed and breed. The reason breed is in here is because part of the sexual process actually involves engagement or engaging the parasympathetic nervous system, not just the sympathetic nervous system, which a lot of people don't know. But if you look at the sympathetic nervous system, you've got a lot of those typical fight or flight presentations, the dilated pupils to take in more light, dilated bronchi and bronchioles to take in more air, increased heart rate, all that kind of stuff. Just remember this when you're looking at your patients. If they look like they're running from a saber-toothed tiger, their body thinks they are. I talk about this all the time, but anxiety, just to put it out there while it's on my mind, anxiety looks like a fight or flight situation because it is. The patient's body is not aware that they are not running from the saber-toothed tiger, right? So don't forget about anxiety. It is both a condition and a symptom, especially in your shock patients, and it is one that you should never sleep on if a patient reports anxiety or impending doom or anything like that. Another important part of perfusion is the regulation of blood flow. A lot of people also don't know that your blood pressure is largely managed, the physical maintenance of that as far as the peripheral nervous system comes from your capillary system, which is managed by sphincters. That kind of counters what most people think. If you hear us talk about like, oh, your blood vessels dilate or they constrict, they do, but that is largely in effect to manage what's happening at the level of the capillaries. The sphincters are controlling how much fluid is going in through those capillary beds so that it can manage that pressure and not have it be too high. If you remember, capillary beds are 1 to 2 cells thick. High pressure will destroy that and will cause an inappropriate fluid shifting. All of that stuff, the membrane will be destroyed. So it needs to be low pressure. That's why the capillary beds are what our body uses as the general way of management for our peripheral blood pressure. The constriction and dilation, though, like I was saying, that does happen. Don't forget about that. When we talk about the level of the capillary beds, that's just something for you to know and consider, especially when you get into administering fluids, because that's where that fluid shifting is going to be happening. Respiration and oxygenation are different things, and ventilation is different. Respiration is the chemical process of gas exchange. Oxygenation is the chemical processes and movement of oxygen in particular. And then ventilation is the chemical process, the mechanical process of ventilation. I'm sorry, I don't know if I said that right. Ventilation is the mechanical process, so that's actual breathing. Respiration, there's an internal and external. That's depending on where it's happening. We'll get to that later, and actually it's addressed in another lecture as well. But the big picture here is, if you remember carbonic acid, that's part of that bicarb carbonic acid cycle that our body uses to help regulate our blood pH. As a part of that, if you remember hearing that shock is usually a state of being acidic or worsened by acidity, that is partially due because of a lack of perfusion and poor circulation. You have a buildup of carbonic acid. That makes the body more acidic, and that worsens the shock state. That carbonic acid needs to make it to the lungs so that it ultimately can be expired, and that process doesn't just build up. You'll see that presentation in anybody with a hypoventilatory state. Depending on how severe that state is, though, it depends on that presentation. Shock can result from all types of things that we're about to talk about here in just a second. And just remember, the body is always going to make efforts to remedy these things. Blood shunting is one of the big things that you're going to hear people talk about. What that actually means is I honestly am not too sure about it, other than there's a pecking order, and it talks about that here in a second. I just don't know at what point the body decides it's going to start doing that, and then I don't know the exact pecking order, other than I do know the kidneys, heart, and the brain are pretty important. Obviously the lungs and the liver as well. All the other things I'm sure or not just I'm sure, but the GI organs in particular are much more competent at handling a lack of perfusion than other organs, because they're kind of designed to. They're going to get blood pulled away when stuff gets really bad. Now, this picture is probably one that you've seen before. It's in every EMT book. I'm pretty sure it's the same one that we used when I was in paramedic school. Just get familiar with it. Honestly, it looks very confusing. I always tell people to take these parts on the outside away if it's too confusing for you at the beginning, and just learn cardiac circulation. That part, that takes time. Honestly, it took me a little bit of time to actually figure it out, but once I figured it out and actually was able to understand how the blood moves through and then it moves out to the lungs, this picture became completely digestible to me. Just keep working at it, and remember that when we start over in the right side here, well, actually, we'll just run through it. So we've got the right atrium. Blood moves from in this case, let's just say the inferior vena cava, into the right atrium, through the tricuspid valve into the right ventricle, and then it's going to pass through the pulmonary valve out into the pulmonary trunk is what this is labeled as. It's the pulmonary arteries. Remember, the pulmonary arteries are the only arteries in the body that do not carry oxygenated blood. This is deoxygenated blood, but they're arteries by nature because they're going away from the heart. Comes out here to the lungs. This is showing you a capillary network in the lungs. It's showing you how this side is the venule side. Venules are small veins, and it branches out into this capillary bed. This is kind of where it gets purple, and then it turns into these arterioles, arterioles, venules, smaller vessels, and then into the pulmonary veins here, which again are the only veins in the body that have oxygenated blood. ends up in the left atrium, passes through the bicuspid or the mitral valve into the left ventricle, and then out through the aortic valve into the aorta. These three branches here, I always mess it up, but I'm pretty sure it's the subclavian, brachycephalic, and then carotid, I think. I could totally be wrong, but those three major branches are where the three main blood vessels for your upper portion come from. So get familiar with this picture. When you get familiar with this picture, learn it backwards, because that's how you're going to learn heart failure. And that is a huge thing for not just shock patients, but also just real world. We encounter that a ton. This is the perfusion triangle, and I actually really like it. It has the three components that I've talked about at the beginning. The heart, which is the pump, the blood vessels, they refer to it as the container, and then the blood, which is the content, and I like that. Obviously, those three are all fulfilling different roles throughout this whole process, but it is required for the three of them to be working together and managing different things all at the same time for the system to be effective. So blood carries your red blood cells, obviously, and various other things. Red blood cells are what it's really gearing towards for this. Reason for that is, does your patient have red blood cells? There are two different types of shock that consider a decrease in blood volume, but there are red blood cells included in that. Always worth thinking about. Because when you think about blood and then you think about those two things, okay, well, we have patients that have decreased red blood cells versus patients who have a decrease in plasma. That can mean very different things. And this is a great example of where anemic patients come in, and just recognition that your patient might actually be anemic and that's why they're not getting better. They don't have the red blood cells to carry the oxygen to where it needs to go. I don't see anemic patients get brought up enough, so I always make a point to bring them up here, because that is not just a condition that's going to worsen shock, but is very much something that can just push them into shock when it might not do that for another person. Blood loss is always the thing that we talk about in here. Blood loss being the big fear, obviously, because once it's gone, it's hard to get back unless you have or work for a system that administers blood product. And unless you're with a paramedic who's trained in that, you're probably not going to have access to that. So bleeds, remember there are medical and traumatic bleeds. It doesn't have to just be from an amputation or something like that. You can also have a GI bleed patient that is very much in this situation. Blood clots have a very unique kind of role for us in pre-hospital, because everybody's at risk for it. It seems like everybody has dealt with it before. But also medications. And when I say like it's hard for us pre-hospital, is when we don't know people's histories. This can also get a little hard to actually decipher and figure out, because patients with a blood clot history or a complex medical history can just present with clots out of nowhere. So always remember that clots are really just one of those things that anybody is going to experience, but can cause massive problems. So the body's neural and hormonal mechanisms are triggered when the body senses the falling pressures. What that's saying is neural is basically, that's your nervous system tapping in, as well as your hormones. So when your hormones, which are proteins that have specific jobs, when hormone levels fall or your organs start recognizing decrease in hormone activity, that can be one of the things where they go, hey, like something's wrong, we need help. Right? And depending on what that means, right, you're going to get a certain type of response. You've got your sympathetic response, which is usually going to be the thing that takes over. Humans generally lie in a bit more of like a sympathetic, like activated, that might not be the appropriate term, but we're a little more ready and primed to get up and run than we are to like the feed and breed kind of thing. Now, the way that we compensate for decreased pressure, two things that I love about this are that it talks about baroreceptors and chemoreceptors. That's not just the form side of it, which I think of with pressure. It's also the function, which I think of with the chemical side of it. So when we talk about compensation, we have the body's actually trying to increase pressure, so it's going to cause vasoconstriction and other things like that. And then you get chemoreceptor involvement, which is when the body is recognizing shifts in the body's CO2 levels, and that's going to affect your respiratory drive, kidney involvement, things like that. Stimulation of these processes usually occurs when you have a systolic that's quite low. You might think 60 to 80 is quite low, and it is. But remember I was talking about MAP earlier? There are certain situations where your blood pressure can be low, but it's not necessarily a bad thing because your MAP is good. We want your MAP to be, oh gosh, I just forgot it too. I want to say it's over 70 to 70, or it's over like 65 is the basement number. I know that's the one that we're saying like this is the lowest it can be, but we usually want it to be higher, and I want to say it's actually like 90. We'll figure that out for sure and put it in the comments or in the video or something. I'm sorry, I can't remember right now. But we talk about that because it's permissive hypotension. You can be at a systolic blood pressure of 90 and still be functional. That's not necessarily a situation that means a catastrophe. But 60 to 80 for sure. Those numbers are not good. Other things that happen, your renin-angiotensin-aldosterone system, that's a pretty interesting system that involves your kidneys, liver, and lungs for management of your blood pressure, which is really interesting. There's some really good YouTube videos on that if you're not familiar with it. But that system ultimately causes the release of ADH, or antidiuretic hormone. If you break that down, anti means against or not, or opposed to. Diuretic means the release of fluids. So this ADH is going to discourage the kidneys from releasing any fluid. That by itself is going to increase your blood volume because you have fluid increase. You also have the increase of preload, like I just was talking about a bit ago. That increase in preload is a very good thing. Even if it seems like it's not much, that's still something. And the heart itself is going to react to that increase in preload. Autotransfusion effect is a fancy word for shunting. We already talked about that. The shunting process is a very interesting and very cool process that the body uses in order to essentially kind of pick organs that can and can't handle a decrease in perfusion. Like we talked about earlier, there are obviously organs that are better at that than others, like the GI. If hypoperfusion persists, your cardiac condition is going to decrease. Obviously, your cardiac output is going to feel the effects of that, and a variety of other things. This is a pretty massive cascade of events. You've got overall tissue perfusion. You have inappropriate fluid shifting, which is part of why if you've ever seen someone who was very sick, they might have looked like they were swollen, like super puffy. That's one of the things that we see in irreversible shock patients is you have that inappropriate fluid shifting. You also have the switch of cellular metabolism from aerobic, which uses oxygen, to anaerobic, which has decreased oxygen levels. So it's happening so an means without, aerobic being the oxygen part of it, without oxygen. It's very, very expensive for the human body to go into anaerobic respiration as the primary energy supplier because it only produces a couple of energy molecules, and it's expensive in the way that it produces a ton of byproducts. Aerobic respiration is a little easier. That's what we do. Our bodies are normally in that. It yields more ATP, and it's not terribly expensive for our waste removal system. Otherwise, you also have the production of epi and norepi. Norepi is actually one of the things that you guys will probably hear more about throughout the advanced program. It's a neurotransmitter that plays a massive role in the peripheral nervous system. Epinephrine is the hormone. Norepi you're going to find at that neuromuscular junction, if I recall correctly. And then again, epi being the hormone means it's going to be circulating throughout your body. We already talked about the pecking order, and then obviously if these compensatory mechanisms fail, the cardiac activity is going to go down. So shock-related events at the capillary and microcirculatory level. Some of this has already been talked about, but I just want to reiterate a few points. Cellular ischemia. Ischemia means there's no oxygen or little oxygen, and when a cell is ischemic, ultimately that cell is going to die, and that becomes problematic because when a cell dies, it ruptures and it expels all of its contents. There's a lot of electrolytes in those cells that we don't want getting out into the extracellular space. They're supposed to be intracellular, like potassium. And that's one of the things that you'll hear me talk about over and over and over is the acidic state, the electrolytes, and then just the overall cellular destruction that happens when you get to these more advanced states of shock because you reach a state of hyperacidity. And that hyperacidity is not only going to mess up your metabolism, cause all of that destruction, but it's going to prevent most of the other compensatory mechanisms that your body's trying. It's going to prevent those from working to an extent. These things can only coexist at the same time, these compensatory mechanisms and all of these unfortunate effects of the biochemical warfare that's going on in your body when you're in a shock state. Biochemical, I mean like the biochemistry side of it. That sounds weird, but the biochemistry side of it when you talk about like the electrolytes and fluid shifting. The lysosomal enzymes, that is just a part of what I was talking about a second ago when I was talking about cellular destruction. Lysosomal enzymes greatly worsen the acidity. It's just one of those things that you'll hear about, but the rest of this is everything I've already talked about before, aside from the last point, which is DIC. You'll have to look up pictures of DIC to really get the gravity of just how, frankly, gnarly it is. DIC is your body's last-ditch effort. This is your body saying, you know what, nothing else is working. We're going to dump all of our clotting factors and to try to do as much as we possibly can to prevent any further hemorrhage and improve perfusion. You don't have to be hemorrhaging for your body to think that maybe you have blood loss or fluid loss or something. So the body's going to do what it can, and that results in DIC. DIC has a pretty high mortality rate. Like I said, you'll have to look up pictures to really get the effect of it. But it is widespread clotting, which results in widespread bruising. The blood does not move if it's full of clotting factors. That's the point, right? So if the liver dumps all of its clotting factors, you're going to have massive clotting throughout the body. Obviously, that's not exactly conducive with life. So again, another example of how the body is attempting to remedy a problem, but unfortunately not succeeding. There are other things that it's going to talk about here. MODS, or multiple organ dysfunction syndrome, is just multiple organ failure. That has a ton of layers to it. Depending on what you're talking about, we don't get to see much of that or analyze that pre-hospital. However, if you're going in hospital, that'll be much more of what you manage and what you actually get to experience and see, because we just see patients that just generally are in multi-systems failure by that point. Not just the process of getting there. But when you do reach the point of multiple organ system failure, you do get activation of other things like it talks about here. The complement coagulation and kallikrein-kinin system. I'm actually proud I said that right. These are three things that we are not going to be going into. If you have gone through them before, you know how complicated they are. I didn't go through these too much when I was in paramedic school either, but I do know they are heavily involved in the clotting system and they are very, very complicated. So I apologize that I can't answer too many questions about that, but I do know those systems get triggered and that it's, when you have the dumping of all of these clotting factors like I was just talking about, it's not just like nothing, right? It results in that massive bruising and overall clot formation for a reason. It's serving a purpose, but again, you can't live with that if it continues on with massive clotting. So some signs and symptoms of MODS are going to be hypotension, the organ system failure caused by hypoxia, which is kind of inferred, but you can make a pretty good case for. Uncontrollable bleeding. You can also argue insufficient tissue perfusion might be someone who has decreased motor activity, fatigue, things like that. That sounds kind of silly, but this is just, these things are all, in a way you can kind of tie them to what you're seeing. Hypotension is obvious, uncontrollable bleeding. Tissue acidosis might be your patient has a high end tidal. Severe local alterations of metabolism might be something to do with like crush injuries or septic infections, things like that. And then respiratory impairment. So I brought up anemia earlier, just in case it didn't get brought up, because again, it's not uncommon for anemia to not get much attention. But anemia has various different types. Just be aware of that. Depending if the patient's even able to tell you, don't be surprised if they tell you a type of anemia and you don't know what to do. Just remember, it has something to do with the red blood cells, hemoglobin, iron, things in that world. Okay, that's anemia. You can have different types of poisoning. If you were thinking carbon monoxide, that's exactly what I was about to say. Carbon monoxide is the situation that we think of the most in this case. Really, the big picture here is just, do you have respiratory impairment that causes a decrease in oxygen and an increase in the buildup of CO2 in the body? You've got your causes of shock. I actually really like this picture, these pictures on the bottom here, because they ultimately kind of show you what's going on here in a simple way. The pump failure, right? So the heart's broken here, anything to do with the heart, and this is the one between pump failure and obstructive shock that I will reiterate a few points on. But pump failure is the pump is the problem. It's not something is happening to the pump in the case of like tamponade or a pneumothorax or anything like that. This is a pump problem. There's a heart attack. There's trauma to the heart, septal wall tear, things like that. Poor vessel function is usually what we encounter the most, in my experience anyways, with infection, overdoses, anaphylaxis. Overdoses are a very, very common reason for widespread blood vessel dilation, which is why a lot of them present with hypotension. And then you have your low fluid volume, which I talked about a little bit earlier, with your hemorrhagic and non-hemorrhagic subclasses. However, this does bring up a really good point regarding vomiting and diarrhea. That is one thing that people, I feel like more people are becoming aware of it as becoming a valuable question, not just for children and elderly, but for anybody. We need to be asking our patients their GI histories. That gives you a huge insight into not only their recent history, but what's actually going on in their body aside from physical assessment. Figuring out recent GI and bladder history is very valuable. So for some causes of shock, this is all kind of the general stuff that I just talked about, but we are going to delve into some of the specifics here in just a second. I need to take a break. I think I'm getting sick. Oops, sorry, I guess you just got some ASMR. That'll be $3. Also, I don't know if you can hear my phone going off in my pocket. I don't know how to turn off these fucking iPhones, like, for notifications. It's so annoying. How much do I have left? 28 of 52. Fuck yeah, man. Killing it. Okay, I guess we'll take this off. Sorry. Sorry. Oh. Okay. So. All right. So now we have, like I said, just some of the points to make about the different types of shock. So hypovolemic shock, like I've talked about before, hemorrhagic and non-hemorrhagic. Hypovolemic, hypo meaning low, vol meaning volume, right? Ic is, I believe, pertaining to. So it's pertaining to a low blood volume is really what we're talking about. Non-hemorrhagic is when we have, I always think of fluid loss, not blood loss. We have fluid loss, meaning it's non-hemorrhagic. That's almost always where your syncope patients come in. A lot of the times, I think patients' presentations kind of get masked by their decrease in fluid volume, like your septic patients and things like that. So just remember, if someone has low fluid volume, we're not just talking about patients that are dehydrated because of another condition like an infection. We're talking about patients that have truly low fluid volume in the case of like nausea, vomiting, diarrhea. Little kids that get sick is always my great example. Kids don't handle fluid loss very well, but that's their primary problem in those situations is the fluid loss. Electrolytes will play a role. If you haven't already figured out by now, their role is with everything, but they actually have a very important one regarding the GI in particular with how fluid moves throughout it and other things. But otherwise, we talked about when I was saying vomiting and diarrhea, there's some other causes like increased and excessive sweating. I always think about that with your hyperthermic patients. Remember, heat stroke is very, very serious and always results in death without treatment. That's where this comes in, right? We're also, in a way, talking about burns. I say in a way because this is still a fluid loss patient. It's just a different consideration, right? Because you also have to remember that these are infection risk patients because their skin's gone, right? Their membrane that helps keep the fluid inside is gone. Therefore, they are leaking. I hate saying that, but they are usually leaking fluid. And that's one thing that we try to manage when we have burn patients is the fluid loss from the actual burn itself. I do appreciate that this also brings up other causes. Ascites is when you have a collection of fluid in your belly. If I understand correctly, ascites in particular is secondary to liver failure or liver injury or damage. Diabetes insipidus. Oh gosh, I haven't thought about that one in a long time because we always talk about diabetes mellitus. I know insipidus has to do with water, or has something to do with either overconsumption or over retention of water. And then osmotic diuresis secondary to hyperosmolar states. That is referencing like your hyperglycemic patients, your type 2s who go into these hyperosmolar states where they just have a ton of sugar and there's not enough water in there to balance out that gradient. So if you think about it, you can dissolve sugar in a glass of water, but then as you take out water and you're dissolving, keeping the same amount of sugar, but your volume of water gets less, when you actually put it in there, it's going to become more and more concentrated. That results in a hyperosmolar state. That's why your diabetics, your type 2s in particular, when they become hyperglycemic, that's why they look so crummy, is they're super dehydrated. We've already talked about this in general, but some early signs of shock are restlessness, anxiety. You also, which I didn't see too terribly much, but I did see it a little bit, was thirst. Makes sense. That's just another sign that the body's trying to take in fluids. They might be at risk for vomiting. Vomiting is a sign that something is wrong. For really anything, the body is always going to try to get rid of something easily if it thinks something's wrong. Easiest thing to get rid of is going to be your stomach contents. If something's wrong, throw up, right? Get rid of it. The heart rate's going to speed up. As the heart rate speeds up, that's usually because the blood pressure is dropping. So if you notice your patient is becoming increasingly tachycardic, that's a direct relationship to what their blood pressure is doing. It's an inverse relationship. As the heart rate climbs, the blood pressure drops. Cardiogenic shock, like we talked about before, is when you have a pump problem. This picture, again, I appreciate it a lot, is actually showing you pulmonary edema. And this is one of the most common situations that I saw as a 911 medic was pulmonary edema just in general, but edema as a whole, whether it was in the lungs, the feet, the abdomen, wherever. Cardiogenic shock, when the pump fails, it's unable to circulate blood. That causes blood to pool in certain areas. That causes the fluid to shift out into areas it's not meant to go. In this case, it's showing you pulmonary edema. In other cases, it might be, like I said, the feet, the abdomen. It just kind of depends. Obstructive shock is when something is happening to the heart. Something is obstructing the heart from being able to do its job. And if you remember the pump itself, there's nothing wrong with it. In the case of cardiogenic, the pump is the problem. There's a heart attack or whatever. In this case, the heart is just hindered from doing its job. In the case of a cardiac tamponade, there's too much pressure around it in the pericardial sac. Tension pneumothorax, there's too much pressure around it, around the whole heart, not just the pericardial sac. And then a PE, there's no blood going back to the heart or from it or wherever, depending on where the clot is in the pulmonary circuit. So really, none of those are the heart's problem. Well, I shouldn't say problem. None of those are the heart's fault, right? It's the heart's problem, though, which is why we see the heart present like this. Distributive shock, the classic presentation is always going to be the spinal cord injury for neurogenic shock as far as the textbook pictures go. And that's because when you have a spinal cord injury and you actually damage that spinal cord itself, you lose your sympathetic tone. Remember what I said about your sympathetic nervous system kind of being the thing that holds us over a little bit? We're kind of up here a little bit more. We're not quite as down here. That has to do with sympathetic involvement. So when you have a spinal cord injury, it causes widespread dilation because now the parasympathetic nervous system is taking a bit of that control over. Not exactly control. It's not like a control, I have this, you have this. It's a balance between the two. And if the parasympathetic nervous system needs to take over, has the ability to, it will. That's its job. Another example being septic shock. Sepsis is one of those things. It's such an interesting conversation, but nobody can agree on what it actually means as far as like a national system for recognizing sepsis like we have for heart attacks and strokes and stuff like that. But it's just big infections, right? It's not that simple, but in the big picture of 911 for us, it is. It's infections that become quite severe. Neurogenic shock, like I already talked about with the spinal cord injuries. Anaphylaxis, you will have whole presentations on anaphylaxis. Super interesting when you look at it from a pathophysiology standpoint. There's a lot of stuff that happens in anaphylaxis that you don't see anywhere else really in these systems, well, except maybe sepsis, because it has immune involvement. I really appreciate anaphylaxis, not just for its airway involvement and how complex that can be, but also what it means for patients long term. That doesn't apply to us much, apply it to us as much pre-hospital, but it is interesting. Anaphylaxis patients are very complex. Psychogenic shock, I always tell people psychogenic shock is the Hollywood shock that we're always talking about where people pass out. This should not stick around. If it sticks around, something else is probably wrong. My second guess is almost always fluids. People are just dehydrated as it is. That's what I saw a lot of. People would pass out from something, whether it was distress or not, which in this case, it's usually because the brain is experiencing such an overwhelming emotional stimulus or just stimulus in general, usually emotional. It's part of what makes it so powerful. But this overwhelming emotional stimulus, and it kind of does like a reset. The brain does that. It's very strange when it's just like, I don't know what to do. Sometimes it just does a reset. In this case, it can cause, and when I say reset, that has various different meanings. In this case, when we talk about reset, we're talking about the fact, the brain is so overwhelmed that it causes widespread vasodilation that results in a fainting episode so that you can get back on the ground in a neutral position so that your brain can be perfused again. But that's normally what should happen, right? And then they get better. This shouldn't stick around, and if it does, it's probably something else causing it. It's probably exacerbated by fluids. Now, shock has its two successive stages that you've heard about before. There's compensated. This is where your patient may have a decent blood pressure, but their heart rate's going to be high. And when I say decent, I mean like technically it's still supposed to be within normal limits, but usually we start seeing people here where you're like, that's a little low. It's unexpectedly low for someone who you would maybe otherwise expect a different blood pressure from. But at this point, the body's handling it, right? That's why it's compensated shock. Here, this is where it talks about your pulse pressure. And I actually really appreciate pulse pressure in this case because when it talks about compensated shock, it's saying, hey, use the pulse pressure while your patient's blood pressure is still good to determine if this is a couple of different problems. Pulse pressure is going to give you an idea if there's pressure around your heart. Remember, your pulse pressure is your systolic minus your diastolic. Systolic is the pressure generated during left ventricular contraction. Diastolic is the pressure in the left ventricle during relaxation. So if there's a ton of pressure, meaning like around the heart, and the heart can't beat the same way, your systolic and your diastolic are going to come closer together, right? There's no difference in those pressures because the heart's not doing this. So think about it literally like this. The pressure gets smaller, so you might see narrowing pulse pressures. You're going to see that while your patient's blood pressure is decent, okay? That's when it matters. So pay attention to that in your compensatory stages. And then you get decompensated. This is when your patient is officially hypotensive, they're tachycardic. This is usually where you have your pretty severe metabolic involvement regarding like their blood pH and things like that. Blood volume decreases more than 30% is kind of what it takes for this to show up. Unfortunately, the systems are beginning to fail at this point. They have failed. That's why the blood pressure fell. And they'll continue to fail. So the patient will ultimately result in irreversible shock, which is terminal. There are always cases where people have survived it, but by and large, we just say that this is a terminal diagnosis in a sense, because you have your body has not only kind of maxed itself out, but at this point, the damage that has been done would be very difficult to come back from. You can think about it like a catastrophic storm, right? You got to think about, hey, how hard is it going to actually be to recover from this? And can you actually do it feasibly, right? So irreversible shock steps in there. Regarding a few things to consider for the scene, there's not really anything. But your primary survey, skin signs. Pay attention to your skin signs, especially for your BIPOC, your biracial and people of color. Their skin signs are not always as obvious. You can pull down their eyelid and look at that color. That's a little bit more regarding like cyanosis, not even just cyanosis. You can check for pallor there too, but just the color of that area is going to give you an idea of like looking at someone's someone's fingernails for capillary fill. Or their color, like on the inside of their lips. If it looks hypoxic or blue, you might see it more easily in those areas. But please don't forget to check those patients more aggressively than you would otherwise fair-skinned people, where it's quite easy to tell. The people of color, you really have to look in some areas, especially when it comes to those blue hues. So don't forget that. Also, the patient's breathing, you should be able to assess that from afar, but always listen to lung sounds. You never know. You really never know when lung sounds just pop up. Always worth checking. Lung sounds to me are a vital sign. IV access is going to be super valuable. National Registry usually just, not the National Registry, but just in general as a culture, it's kind of just, hey, get some IVs going, push some fluids. That's dependent on the patient's condition and your system that you work in, whatever that fluid administration looks like, but at least get your IV. Fluids will probably come into consideration. For your history taking, make sure you're looking for specifics. Excuse me. I always make a point to ask, have you had any falls recently? Have you had any coughs, any skin irritations, or GI or stomach bugs? Those are really valuable. Just in general, they kind of target certain points. Oh, and have you had any problems going to the bathroom? When I talk about have you had any GI problems, I also talk about pee. Have you had any burning or anything when you go pee? Super valuable question. Sepsis in elderly people from UTIs happens all the time. So those are questions I just ask. In addition, few other things I always ask, do you consume any drugs, alcohol, or marijuana? It's just a lot of people out there don't consider marijuana a drug when you ask that question, so I find it valuable to say, do you use any drugs, alcohol, or marijuana? And then another question I like asking, do you have all of your organs? Have you had any of those organs removed? And then another question that I found valuable regarding patient history, sorry, these are just kind of all over the place, but they're just in addition to your sample history, is do you have any, instead of asking people what's your medical history, because people kind of get silly when you ask them that question, they don't always tell you everything that you want to know. I ask them, do you have any issues with your brain, heart, lungs, liver, kidneys? They might not be able or remember to tell you that they have lupus, but when you say that, they'll say like, oh yeah, I have a kidney doc. Oh, well, why do you have a kidney doctor? Oh, well, I have lupus. Okay, well, so that's one of the things that I've learned over the years is valuable for asking regarding complex medical histories. If you even have the ability to do that with some of these patients, that's a nice way to knock some of those questions out. Remember, blood thinners can make bleeding injuries worse, and then not just blood thinners, but if someone has a history of strokes, not just that, but travel and occupation that kind of lends itself to clotting, that's also a valuable area to just maybe peruse in someone's history as their clot risk. Secondary assessment is going to be your head to toe, depending on the patient's condition and overall presentation, depends on where you might do this, when, why, how. Secondary assessments are very nice, but they're not always appropriate if your patient has any issues with their primary areas, like their ABCs. If you don't get to a secondary assessment because you're focused on the ABCs, that's okay, but try to delegate it to someone else who's free if you can. Reassess every 5 for unstable, every 15 for stable. Let's be real, the National Registry isn't going to be giving you stable patients for the most part. They want you to remember unstable is 5. 15 for stable is still important to know, but by and large, the patients that you're going to be assessing or running through your scenarios are going to be critical or unstable patients. These are people who get rapid transport, they get treat for shock, Don't forget treat for shock. Positioning, supine or Trendelenburg's. I do supine. High flow oxygen, IV access, warmth, right? Crank up the heat in your ambulance, cover them with blankets. Oh gosh, and I can't remember the last one now, but those are all your treat for shock. Like I was just talking about, the basics for that, it does depend on the condition. When we say treat for shock, that's on your National Registry sheet for your medical and trauma assessments. The actual treatment of the shock depends on the condition that they're in. You're going to see pretty much everything, like I said, still surrounds that idea of get an IV, give them oxygen, transport them, keep them warm, supine position. But the idea here is also within the 60 minutes after the injury for the golden hour. That's what this whole thing is kind of going behind, of saying like, hey, you have an hour to do these things. Don't sacrifice any of your time to be doing things that are not appropriate for the patient. We only have an hour to get the patient from recognition that they have an injury or an illness to the hospital for treatment. So just remember that when it comes to deferring, that's why we can defer other things, like the secondary assessment. But that being said, there's still expectations for what you should be doing within that golden hour. And that's what this is talking about. Still the same thing. Initial management, vital signs every 5 minutes, IV/IO access for fluid boluses. I always tell people 250 if you don't know, 500 if you do know regarding their medical history. And the caveat to that is that lung sounds before, during, and after, right? 250 is a decent place to start for someone who you don't know their medical history. Everybody, for the most part, could benefit from 250 mLs. That's why you'll find a lot of people do that. But again, if you notice signs of inappropriate fluid shifting, you just stop it, right? Listen to lung sounds before, during, and after for any of these situations. That's a fluid rule. Otherwise, it says the same thing over and over. Regarding IVs, it just kind of depends on what your system prefers. The systems that I worked for preferred large bore IVs, being your 18s to even 20s. But 16s was the thing as well when I started out. I don't think it's necessary to do a 16. I'm an 18 girl. I've been using 18 to 20 gauges, and I've had a pretty decent time with it. But remember, that is all dependent on what your hospital system expectations are. You do need them. They are necessary, not just for fluids, but so when you show up to the hospital, they can pull blood, administer meds, whatever kind of stuff they need to do. So IVs are very helpful for us, but even more so for other people. Special considerations in fluid resuscitation. I gave you kind of my, in the field numbers. These are the actual numbers. You can do 20 mLs per kilo of warmed isotonic crystalloid solution. Be aware these days they're not as much encouraging isotonic anymore. They never really have. Lactated ringers is much more preferred by pretty much every provider that I talk to. Saline is it's fine. Quite harmless when we talk about, or the way that we talk about it, but it's not as harmless as it sounds. So just be aware that you might hear some changes coming about regarding isotonic fluids, and just using them for everybody. You might be, the conversation might hopefully be going to, hey, we have saline and LR or something else like that, so that we aren't just giving isotonic fluids. If you have that conversation with someone like a flight medic, they'll know exactly what I'm talking about. But for now, we're just talking about isotonic, which is saline. 20 mLs per kilo is a great place to start. Like I was saying, it's not all that far off from what I was saying is my basement of 250 mLs if you don't know their medical history. But as always, if you're giving fluids, just monitor them. Treating hypovolemic shock, this is just IV fluids. It also mentions monitoring end-tidal CO2, which I love. Patients that are septic are going to have higher levels of, septic. I was thinking of sepsis, but it's also hypovolemic. If someone is hypovolemic, you'll see changes in their end-tidal CO2 as well, but especially the septic patients. And then you transport them. Treating your cardiogenic shock, you just want to maintain a systolic over 90. That's kind of what they say for cardiac patients in general. Position of comfort and administer high flow O2, IV access and fluids at a TKO rate, depending on the type of heart attack, depends on whether this patient and various other things, but where it is will play a large role as to what your patient's presentation is going to be. If you've heard it before, inferior, so at the bottom, kind of front bottom and right side of your heart is very vulnerable when it comes to heart attacks because it'll drop your blood pressure because preload. Preload is the volume going into the right side of your heart. So when you're having a heart attack there, they're usually going to be hypotensive. That's one of the things that we look out for in anybody, but obviously your right-sided heart attack patients. So if you're rendezvousing with an ALS unit, this might involve assisting them with an EKG, but that's not necessarily something they teach in this class. It just might be something that you do. Obstructive shock, like we talked about, cardiac tamponade and tension pneumothorax, you're going to give them high flow O2, start your IVs, transport. For these, just consideration of C-spine, spinal immobilization in general, whatever that looks like for your system. A lot of systems are kind of willing to sacrifice some C-spine these days if it's a position of comfort for a traumatic patient with ventilatory or respiratory issues like you might see with a tension pneumo. I think that's great. If your patient isn't reporting complaints that warrant spinal immobilization and they're better off in an upright position, I think that's fine. It'll be interesting to see where that kind of, or where we go in that direction over the next few years. PEs, if you have a patient who you're convinced is having a PE, they just need rapid transport. You can give them fluids. It makes me a little nervous giving a patient fluids that I think has a blood clot. That just depends on your system, but that's what the book recommends. Whatever your system protocols, all that kind of stuff say, that's what you're going to follow. Treating sepsis is, like I said, just very dependent on the hospital system. If you work for a system that has a code sepsis, then you'll just follow whatever protocols they have there. But otherwise for us, these patients usually need a lot of fluids. Rapid transport, high flow O2. Don't be surprised if you have to manage airways for these guys. We oftentimes find them when they're quite sick. So give them fluids if they need it. Treating neurogenic shock, keep them warm. These guys can't shiver if their spinal cord injury is severe enough. Obviously they can't move, but that's an important one to remember, shiver. Maintains appropriate spinal immobilization, make sure you're managing their airway if they need it, and then ventilate them if they need it. Anaphylaxis, this shows you an EpiPen. Again, you'll have multiple other conversations about this. EpiPen takes priority. As advanced EMTs, you can also give albuterol and Atrovent in a duo neb, and that's awesome. IV fluids, and then, airway management. The best airway management is going to be the epi from the start, and then whatever else you can do afterwards. ALS rendezvous. Get a medic or like a flight team or someone that you can around that has a higher level scope, because even when I was out in the field, I was on my way to the hospital so I could bring my patient to someone with a higher scope. These guys can be really messy. Don't forget that they are airway, breathing, and circulation patients compared to the majority of the patients that we just talked about. And then regarding psychogenic patients, remember we need to do a good head to toe, figure out did they fall, did they hit their head, did someone catch them, did they definitely lose consciousness, did anything else happen that this might actually be masking, did they have complaints beforehand like chest pain, dizziness, something like that. Bystanders are going to come in a lot for this. These are going to be a lot of your treat and releases that you see in the field. That being said, do not be afraid to not just brush these calls off. These calls usually warrant some pretty decent assessment. If you have a patient who is a psychogenic shock patient, there's usually going to be some kind of emotional factor involved. Just take that into consideration. You still need to do an assessment if they're not getting better. Remember, it's probably something else like fluids. All right, so if you guys have any other questions about that, drop them in the comments. Otherwise, I will see you guys next time. Thank you.